Good afternoon, everyone. Welcome to today's 2021 Open Summit Part 3. So I'm Sherilyn Houle. I'm an assistant professor at the University of Waterloo School of Pharmacy and a member of the Open Executive. And co-hosting with me today is Annalise, a research officer at the University of Toronto. So before we begin the presentations, it's important for us to reflect upon the lands that we are on today. Here in Waterloo, I respectfully acknowledge that I work on the traditional territory of the Neutral, Anishinaabe, and Haudenosaunee people. The University of Waterloo is situated on the Haldimand Tract, the land promised to the Six Nations that includes 10 kilometers on each side of the Grand River. Now, recognizing that we have individuals from across the province, the country, or even internationally joining us today, I invite you to reflect and acknowledge the ancestry of the land that you are on and the commitments made to these people. As today's summit is co-hosted by Open and the Center for Practice Excellence, we would like to take a moment to review what we are about. So Open is a team of multidisciplinary researchers that work together to evaluate the quality, outcomes, and value of medication management services that pharmacists and other healthcare professionals provide. We are fostering knowledge translation and exchange, building capacity in medication management research, and addressing the needs of Ontario's vulnerable populations. Now, hot off the press, we do have a brand new website for Open. So after today's session, I invite you to visit that webpage at open-pharmacy-research.ca and check it out. And now to talk about the Center for Practice Excellence at the Lesley Faculty of Pharmacy. It generates and utilizes leading edge medication management research and innovation to drive educational programs that practice and revolutionize patient care. The CPE brings together practitioners, researchers, staff, students, and professionals from around the world to serve as a network to access expert advice and research. So as many of you know, this year's Open Summit was divided across 4 days, with today being the third session. The next session on improving the system will be held on Wednesday, March 3rd from 1 to 3 p.m. Eastern Time and will follow the same format as today's event. And to register, the website is posted below. A little bit of housekeeping notes for us. So obviously we encourage you to register for the remaining day of the summit next Wednesday, if that interests you. We will be audio and video recording today's session, and those recordings will be made available on our website shortly should you wish to access them or bring them to somebody else's attention to watch. In terms of questions for our speakers, we're going to be using the chat box feature in Zoom to do this. So please use that chat box to ask any questions or provide any constructive feedback that you might have for the presenters. Finally, we'd like to remind our participants that the aim of the summit today is to disseminate and share knowledge generated through research. However, please do acknowledge that some of this research being presented is still in progress, so we do ask that you refrain from sharing any specific results and data that you hear today, including through your social media accounts. So on this slide here is a schedule of what today is going to look like. So following this welcome, I will introduce our plenary speaker, and that will be followed by a Q&A session with her. And then we will have 2 oral research presentations, a brief break at around 2 o'clock, and then 3 more oral research presentations after that. And following this, we will have discussant remarks, which will summarize what we've heard throughout the day and provide some interesting perspective on that. And then we will close for the day at around 3 o'clock. So now I am pleased to introduce our keynote speaker for today, Tara Gomes. She is an epidemiologist, a principal investigator of the Ontario Drug Policy Research Network, and a scientist at St. Michael's Hospital and ICES. She is also an assistant professor at the University of Toronto, and she holds a Canada Research Chair in Drug Policy Research and Evaluation. Her research program focuses on pharmacoepidemiology, drug safety, and drug policy research, with a specific interest in developing evidence to inform policies related to the safety of opioid use across Canada. Over to you, Tara.
Thanks so much, Sherilyn. And thank you for inviting me to present today. It looks like a really exciting agenda and a really important one. Clearly, studying and understanding the opioid overdose crisis is something that has been a big focus of the work that I do, and one that I think has important implications for pharmacy practice as well. So What I wanted to do today was just talk a little bit about some of the ideas that I have around the potential role and of pharmacists during this crisis that we have across the province. In terms of disclosures, I don't have any financial affiliations or other affiliations with pharmaceutical, medical device, or communications groups, and all of my research is funded through grants from the Ontario Ministry of Health and CIHR. I often start with a figure similar to this, just to kind of remind everybody why we're here and why this is such an important topic. This is simply a trend of opioid-related deaths across Ontario over the past 25 years or so. And when I first began getting involved in this area around 2008, we had seen over the past 5 or 7 years that there had been some increases in opioid-related deaths that were concerning. And there was concern that this was related to rising rates of prescription opioids, and there was a need to develop drug policy and an evidence base to better understand what was happening. And what we've seen since that time is that these rates have continued to climb, and concerningly, around 2010 to 2012, when prescription rates for opioids actually started to plateau or even decline because of a lot of the policies and the stewardship initiatives that were undertaken across Canada and even more broadly across North America, we didn't see that same trajectory with opioid-related deaths. And instead, we started to see these rates increase even more quickly. And when you look at 2015 onwards in this figure, you can see that there's just been an acceleration in the rate of opioid-related deaths across the province. And this is really divergent from what has been happening on the prescription side. We can understand a little bit better what's been happening here if we look at the opioids contributing to these deaths. If we look between the years of 2000 and 2011, oxycodone was really the opioid contributing to deaths that climbed most dramatically. And that aligned pretty well with what we saw on the prescribing side, with increased dispensing of long-acting oxycodone of that period of time. But then things started to change when prescribing rates started to decline. We see less involvement of prescription opioids in fatal overdoses after that point in time, which I think is closely tied to the changes that we saw in the way in which opioids were being made available within communities. But around this time, we also started to see large increases in the opioid overdoses that were coming from the unregulated or illicit drug supply, and specifically with those that were involving fentanyl. And this isn't fentanyl that would come prescribed like a fentanyl patch, but this is fentanyl that was being manufactured elsewhere, brought into Canada, and being mixed in with the illicit drug supply. And I stopped this figure at 2016 so that we can kind of see some of these shifting patterns. But if I extend these patterns out to 2019, you can just see how overwhelmingly the unregulated supply of fentanyl is driving the fatal overdoses that we are seeing across Ontario now. And this has only increased in 2020 with the introduction of a pandemic on top of the opioid epidemic that we're grappling with. So what we've really seen over the years is quite a transition towards a huge increase and focus on the unregulated drug supply in terms of what has been driving fatal overdoses across the province. And so as we're thinking about this changing environment, I think it's important to think about what the role of pharmacy practice can be in addressing this. And I think we need to come at this from multiple different perspectives. So I'm just going to go through now a few ideas that I have, and I'd be very interested to hear what others think in the discussion section for this presentation. So I think the first thing is that we do have to continue to focus on prescription opioid stewardship when thinking about opioids that are being dispensed to manage pain. There is still about 20 to 25% of opioid-related deaths in the province that have prescription opioids as contributing factors. So there continues to be a role of stewardship around prescription opioids to try and address this issue. And there's a huge body of evidence that shows that approaches focused on dispensing smaller quantities of opioids, especially at initiation, can avoid opioid overdoses as well as prevent longer duration opioid use. And that's something that is well within the wheelhouse of what pharmacists can do when receiving prescriptions and dispensing these to people, especially at time of initiation. There's also a lot of evidence around the role of higher doses of opioids and combined use of these drugs with benzodiazepines and gabapentinoids, leading to increased risk of overdoses. And again, there are opportunities to intervene with patients when they are getting prescriptions filled to counsel them on the potential risks of the higher dose opioids that they're getting or the combined use of medications. As well, we often find that with people who are getting co-prescribed opioids and benzodiazepines, those two prescriptions don't always come from the same physician. And sometimes the prescriber of the opioid may not be aware that that patient is also getting a benzodiazepine from another prescriber. So there's a really important role for pharmacy practice in identifying these potential drug interactions and speaking with the prescribers to make sure that they're aware of the different medications that patients are on and helping them come to an approach that can keep the patient's safety in mind and try and ensure that if an opioid is being prescribed, it's being prescribed in as safe a way as possible, and that the patient and the physician are aware of those potential risks. As I mentioned, this crisis that we're in right now is predominantly coming from the unregulated or illicit drug supply. So we need to think about the role of pharmacy practice in helping address some of the harms that are coming through from that side as well. And I think that one of the major roles that pharmacies and pharmacists play within this crisis is providing access to treatment and harm reduction. So pharmacies across the province provide patients with access to methadone or buprenorphine or sustained release oral morphine for treatment of opioid use disorders. And also the provincial government now provides funding for naloxone kits that can be dispensed to any Ontario resident across the province. And this is a huge opportunity to improve access and availability of these evidence-based treatment and harm reduction programs and products across the province. But we continue to see that not all pharmacies will dispense OAT or will provide naloxone kits. So when we look at data from 2018, just over half of pharmacies across the province were dispensing naloxone kits. Now, I think that number has gone up considerably since that time, but we do know that not every pharmacy is carrying naloxone kits and having them on hand immediately when somebody might come in and ask for one. And we know that that's a really important moment for people to access a kit. And if they have to come back the next day, they may not come back, or they may not get that kit in time. So I think we need to ask the question as to why we aren't really focused on making sure that all pharmacies across the province are in a position where they can carry and dispense both OAT to treat opioid use disorders, as well as naloxone kits for providing that access to harm reduction. And we've done some work, some qualitative work, interviewing people who are accessing naloxone in particular from pharmacies to understand their perspectives on this way of getting access to these kits. And some of the themes that came out of this, I think, were really interesting and important for pharmacies and pharmacists to understand. So first of all, there were a lot of benefits that were raised around this new way or newer way of accessing naloxone, and that this really creates an opportunity for broad access to naloxone geographically across the province in parts of the province that wouldn't historically have had access to kits through community-based services or public health, because those are typically not as common as pharmacies, and so it can be harder for people to access. Pharmacies also just have extended hours. They're open on weekends, they're open on evenings compared to some of the community-based and public health programs. And so this really opens the door to access for people at a time where they may not be able to access these harm reduction products elsewhere. And these are both seen as real benefits of the way in which naloxone was being rolled out provincially. But there were some challenges and barriers that people experienced that I think that we can kind of try to better understand and think about how we can adapt practice within pharmacies to address. One of the first was that recently in 2018, the provincial government removed the requirement for people to show a form of ID when getting a naloxone kit for a number of reasons. Some people don't have ID. Some people, because of the stigma around drug use, were not comfortable identifying themselves within a pharmacy. And despite that removal of a requirement for ID, we continue to hear from people that some pharmacies are demanding a health card or some form of ID before dispensing naloxone. So I think that's one easy thing that can be changed that can help improve accessibility for people who are looking for a naloxone kit. The other suggestions that came out of this work were that there should be opportunities for pharmacists to really normalize access to naloxone. particularly among the chronic pain community. So thinking about opt-out policies where people who have a certain, have chronic opioid prescriptions above a certain dose, or people who are receiving OAT are just offered a naloxone kit as standard policy. And that way it really normalizes this as a potential life-saving product that you can have in your home or on your person to try and intervene, and can really change some of the perceptions around naloxone, particularly within the chronic pain community. And finally, there were issues raised around privacy for people when coming into a pharmacy and asking for a naloxone kit, as well as during that training that the pharmacists provide for naloxone administration. And there were a lot of discussions around thinking about it, in particular in smaller community pharmacies, where people might have a really hard time going up to a pharmacist and asking about naloxone or getting trained if they're concerned that they might have, you know, family, friends, neighbors who are also in that pharmacy who might overhear, and it might make the person accessing the naloxone uncomfortable. So thinking about ways in which more private spaces can be provided to provide that naloxone training and to have those conversations with people was another potential area of improvement that was raised by people who were looking for naloxone kits from pharmacies. If you think about other opportunities for pharmacy practice, I think another one, and this spans across, you know, beyond just opioid use disorder, but is another important area is really thinking about the community that you serve, the clients you serve, and what resources can be made available. So if you are thinking about whether your community has a high prevalence of opioid overdoses, whether there is a high prevalence of people transitioning out of prison or experiencing insecure housing or having challenges accessing primary care, these are all social determinants of health that we have seen are associated with people having an increased risk of having a fatal overdose. So coming up with services and resources that can be made available to people who come into your pharmacy to help point them in the right direction and let them know about opportunities for access to treatment or harm reduction can be a huge opportunity for pharmacists to play a really important role in people's lives. And I think if we think specifically around opioids, knowing the availability of overdose prevention sites or consumption and treatment services within your community, whether there are RAM clinics where people can get rapid access to addiction services, these are the kinds of things that should be fairly accessible to pharmacists. And if you have that information on hand, because people go to pharmacies so frequently, this can really create an opportunity to share that information and allow people to navigate the healthcare system and find access to the resources that they need. And overarching all of this is an issue that comes up regularly when I speak with people who use drugs and people who are interacting with the healthcare system, and that is the need to create safe spaces for people. This is a population that has experienced stigma within the healthcare system, oftentimes trauma in their lives, and challenges really being listened to and developing those mutually respectful relationships with their healthcare providers. And there's an evidence base out there that really demonstrates that the language we use, the words that we use when talking either between healthcare providers or when healthcare providers are talking with their patients can really change the way in which people respond, the kinds of care that people get, and that can have huge implications for people with their downstream health. I've put a couple of quotes here from different qualitative studies we've done where these kinds of themes have come up. And I think it's really important for us to take a step back and really think about the language that we use on a daily basis. The table that is on the right here is from the Global Commission on Drug Policy, and I think is just one simple tool that people can use to look at the types of language that are recommended right now when considering how we talk about this issue, how we speak with people about their drug use and about their needs, and try and create the most safe environment for them to be able to share their needs and share what issues they're encountering so that you can develop that relationship with people and provide them with access to the services that they're looking for. And then finally, I can't have a presentation these days without talking about the COVID-19 pandemic. And I think that this is unfortunately the arrival of this pandemic has really just amplified the issues that we have been seeing with the overdose crisis across the province. Since the state of emergency was declared in Ontario in mid-March, we have seen an increasingly toxic, unregulated drug supply. There have been gaps in access to community-based services, especially in the first wave, due to challenges with people accessing PPE, required shutdowns at different stages during the province, and challenges staffing some of these programs. So we've seen that access to these types of services have, in some cases, declined. There have been disruptions across the board in people's access to healthcare providers. And the public health measures that have been introduced that are required for COVID-19 around social distancing and physical distancing has led to more people being isolated. And for people who use drugs, that can be quite a dangerous circumstance, because if you're using drugs and are using drugs that are increasingly toxic, and you don't have the normal network of supports and safety nets that you've had in place previously, it can create a very dangerous situation where people can overdose and not have somebody there to intervene. And without that intervention, obviously, those overdoses can be fatal. So I think for pharmacists, there are a lot of opportunities that have arisen during the pandemic to help play an important role in this. And they come down to a few different factors. I've listed a few of them here, but I think there are more. CAMH released a guidance document around OAT carries and providing recommendations for providing more take-home doses of methadone and buprenorphine. And we've been doing some early work looking at that, and it showed really dramatic, rapid changes in the carries that people were receiving since the middle of March of last year. And I think that the pharmacists, in collaboration with physicians, have played a really important role in allowing people to continue treatment in a way that does not require them to be coming to the pharmacy every day, and allows them to maintain that level of physical distancing that is being required, and doesn't need people to be out in the community as much anymore. So I think that's an important role in understanding that guidance document and working with prescribers to implement that change, and pharmacists have played a huge role there. I mentioned naloxone a couple of times. This is obviously a huge role for pharmacists, and I think continues to be, especially as some of these community-based services have had to have different hours, and as the unregulated drug supply has become more toxic. So making sure that you have naloxone on hand and that it is accessible as possible, I think, is a continued role for pharmacy practice. And then finally, and I know there's a presentation, I think, later this afternoon speaking more about this, but Health Canada has introduced temporary exemptions for prescriptions for controlled substances. So I think this has created some opportunities for pharmacists to help bridge some of the gaps that have been introduced during the pandemic, when people may have had challenges getting in to see a healthcare provider to get renewals on prescriptions for OAT or for opioids to manage chronic pain. And if those gaps persist and people can't get access to their prescriptions, it can throw them into withdrawal and put them at risk of accessing the unregulated drug supply that is so toxic right now. So pharmacists really have an important role to play in helping extend prescriptions where necessary, help bridge those gaps, and make sure that people can continue to access opioids without disruptions, as everything else in our lives is being disrupted right now. So just in closing, I'll point you to this multimedia project that I was involved in called the Opioid Chapters. It came out a couple of years ago, but was really an attempt to give people an idea of some of the different stories and life trajectories of people who've used opioids or have been involved in community-based programs or clinical programs for people who use drugs across the province. And I think that sometimes it's really helpful to hear a variety of perspectives on this issue. It is a really varied issue with a lot of people coming at this from different perspectives and having different life experiences that contribute to their perspectives on this. So I found this a really informative project for myself to work on, to hear all of these different stories. And you can go to this website and peruse a few of them, and I think it can be very helpful for people working in this area. There's also a recent Globe and Mail article that just came out, I believe it was last week, by Andrea Wu, where she just provided really brief stories of people who have lost their lives to opioid overdoses across Canada in the last couple of years. And I think that just really helps bring faces to the numbers that we talk about so much. I think we've all talked about this opioid crisis for years, I think decades, or at least a decade in my circumstance. And I think it's really helpful to bring it back to who we're trying to help and their needs, and better understanding that can help us really improve the care that we provide. So I will stop there and pass it over to Annalise.
Thank you so much. That was an absolutely wonderful presentation and such a great start to our day. I can see Derek Jorgensen in the chat has just said great practical suggestions. And I'd really like to echo that. I think particularly your slide on kind of language and, for lack of a better word, do's and don'ts in different situations is really, really key, especially for young professionals who are coming into this field and gaining experience. I can see Derek has also followed up with a question. I'll invite other people to type any questions that they might have for Tara into the chat box. So Derek says, thank you again. Do you have any suggestions or tips for pharmacists regarding the emerging safer supply programs?
That's a really great question. I grappled with whether to include that and felt that given the time constraints I wouldn't, but I'm glad that you brought it up, Derek. I think pharmacists are going to play a really important role. So for those of you who may be less familiar with this, these are programs where people are being provided with immediate release hydromorphone products. So essentially dilaudid to provide them with a safer alternative to the unregulated drug supply. So typically people are getting 8 milligram tablets, and they're getting several of those daily dispensed, often 4 or more, to help provide an alternative to that unregulated supply. I think pharmacists have to play a really important role. There end up being large amounts of hydromorphone that will be dispensed through safer supply programs when they're being provided. And patients who are part of these programs need to have adequate follow-up and supports within the clinical care that they're receiving. So there are some guidance documents that I found really helpful in understanding how people who are already providing some of these programs are recommending that they be rolled out, and the kinds of supports and documentation that should be required for physicians and pharmacists who are taking on patients through these kinds of programs. They are still few and far between across the province. So I would say for most people within their practice, they may not see this come up, but we are seeing Health Canada invest in pilot programs, and given what we're seeing with the street supply of drugs right now, an increasing push for people to provide access to a safer supply of drugs. So I would urge people to become familiar with this, to see if they can better understand if there are clinicians within their communities who are providing these services, and if they're approached by a physician who is looking to provide this to their patients, really speak with them to understand how you can support that. I know there can be concerns about dispensing large amounts of drugs to be used in this way. So really understanding what the program is, how these patients are being supported, and how you can feel comfortable with that role, I think is something that I hope people can keep an open mind to. And I can add to the chat box, hopefully, maybe when the question and answer period is done, a link to that document that people might want to take a look at to better understand some of those programs.
That would be wonderful. Thanks, Tara. We'd be happy for you to pop anything into the chat box. I'm going to ask, Jen Lake popped a question in. I think I'll ask that, and then maybe, Philip and Wasim have also put in questions. So maybe there can be a bit of discussion in the chat box, but just to get to Jen's question, she says, I really like the opt-out of naloxone option for pain management for patients. Is any jurisdiction doing this? And if so, is there data of benefit or data that supports this?
That's a great question. I am not aware of anywhere that's doing this. This actually came up through recommendations of some of the patients who are going into pharmacies and the qualitative work we did. So I'm not aware. There may be individual pharmacies, there may be regions that are doing this kind of thing, but I'm not aware of that. There is evidence that more access to naloxone to communities, and a lot of that comes out of BC, can help reduce fatal overdoses. And obviously this is, there's a clear link between those. So it becomes a question of the investment and the cost of these products against, the evidence of when and where they will be needed. My personal perspective is that we should be getting this out as broadly as possible. And when we're thinking about people with chronic pain who are getting sometimes very large doses of opioids, having a kit in your cupboard can't hurt. And if it has the off chance of saving a life if somebody inadvertently overdoses, I think that is, well worth the cost. So there is evidence of benefit of naloxone broadly. I don't think specifically the opt-out policies, but I think that there's a lot of pragmatic reasons why it would be an appropriate way to go.
Thank you so much for that. Tara, if you want to follow up, there's 2 comments in the chat for you, and Jen just says, thank you, I agree with pragmatic approaches and reasons. I will now turn it back over to Sherilyn, who's going to introduce our first oral research presentation, but just want to thank you very, very much on behalf of the Open Summit, Tara, for joining us today and for that fantastic presentation.
No problem, thank you. I'll try and tap away a few answers in the chat.
Thanks.
All right, so I'm happy to introduce the first speaker for our oral presentations today. And our first speaker is Nyasha Gondora. She completed her PhD in neuropharmacology in 2020 and is currently a postdoctoral research fellow at the University of Waterloo. Her current research project focuses on understanding the role of pharmacists in opioid stewardship. Apart from research, she is passionate about education and is a certified academic consultant. In her spare time, she shares her passion for science through blogging on topics of science, health, and wellness. Her presentation is titled, "What Role Can Pharmacists Play in Opioid Stewardship? Findings from a Comprehensive Scoping Review on Opioid Stewardship Interventions by Pharmacists." The floor is yours.
Oh, Nyasha, you're just on mute.
There we go. Thank you very much for your kind introduction, Sherilyn, and thank you all for being here this afternoon. So over the past few months, we've had the great privilege of delving into the literature to explore the question, what role can pharmacists play in opioid stewardship? And today, I'm looking forward to sharing our findings. But before I proceed, I would like to acknowledge that this work was conducted in partnership with the Opioid Evidence Group, whose members are listed here on the slide. As well, this work was funded by the Canadian Pharmacists Association, who I shall now refer to as the CPHA. Looks like my slides are taking a moment to advance. Please excuse me. Here we go. So looking at the big problem, the opioid epidemic is a global concern. In fact, 16 million people worldwide have had or currently suffer from opioid use disorder. And here in Canada, there's great concern as we're currently the 3rd highest opioid consumer behind Germany and the United States. Looking at the statistics for opioid-related mortality and morbidity, the numbers are staggering. Let's just take a look at the graph here. It shows the numbers and rates per 100,000 of opioid-related deaths in Canada by province from January to June 2020. So just looking over the 6-month period, there were over 2,600 opioid-related deaths, the majority of which were here in Ontario, where there were over 1,000 opioid-related deaths. So this really emphasizes the importance of opioid stewardship. So this leads us to the question, are pharmacists a part of the solution? And the answer is absolutely yes. Pharmacists play a central role on healthcare teams, and they also have frequent interactions with patients. So this puts them in a good position to promote opioid stewardship. Now, it's important to note that pharmacists are already involved in opioid stewardship through some of the activities we can see listed here on the slide. However, there is no current summary of pharmacists' opioid activities or the impact of these activities. So this leads us to a research question. What types of interventions or activities in opioid stewardships are reported in the literature, and what is the impact of these activities? So to address this question, a scoping review was conducted according to the methodological framework of Oxy and O'Malley. 6 databases were searched. And with regards to inclusion criteria, patients of all demographics were included. And all studies, whether they were qualitative, quantitative, mixed methods, or other, were included as long as they emphasized the role of pharmacists in opioid stewardship, either independently or as a part of a multi or interdisciplinary team. And this work was conducted, and by this work, I mean the screening, extraction, and synthesis of the data was conducted independently by 2 reviewers, and the Opioid Evidence Group, which is a group of subject matter experts here in Canada and Australia, provided feedback and direction at every single stage. So this has really added extra rigor to our methodology. So let's look at what we found. So this schematic here just highlights, how we came down to include 77 articles from the original 13,000 that were identified in the initial search. And looking at the demographics of the included studies, what we can see here is that with regards to study location, the majority of these studies were actually conducted in North America, mainly in the United States. And this aligns well with the knowledge that the United States is currently the highest opioid consumer in the world, and therefore bears a large proportion of that global burden. And looking at the practice side, the majority of these studies were conducted either in a hospital, clinic, or in a medical center, followed by a community pharmacist, academic institutions, and other. And by other, we're just referring to sites like a dentist office, which would not fall into the major categories that we have highlighted here. When it comes to leadership, 58% of these studies were led by pharmacists, and 35% were conducted in multidisciplinary settings where there was collaboration, and 6% of these studies were conducted by pharmacy students. And it's really great to see the next generation of pharmacists contributing to opioid stewardship. So when we had obtained the literature, there was great diversity. So we had to find an effective way to characterize our findings. So we took 2 specific approaches to this. So the first approach was to characterize our findings according to the pharmacist's scope of practice in the given studies. Now, scope of practice has been identified by the CPHA, or rather, I'd like to rephrase that. There are 4 major domains of pharmacist scope of practice that have been identified by the CPHA, which are prescriptive authority, dispensing authority, medication administration authority, and health test authority. So we decided to use these 4 categories as the major ones for scope of practice domains, but we also approached the literature with an open mind. We were trying to evaluate what other domains could we identify in addition to these 4, and education was one which we identified, which was recurring in a lot of the literature. And as you can see here, I put an asterisk next to education just to identify that it's not part of the CPHA major 4 domains. All right, and what we see here is that education is actually the most predominant domain, followed by dispensing authority, prescriptive authority, health test, and then medication administration authority. So after we had classified our data according to the scope of practice of pharmacists, the next step was for us to identify the exact interventions that pharmacists were actually involved in. And this slide here just highlights 6 major interventions that we're able to identify. So 4 of these 6 are fairly self-explanatory, and these 4 are academic detailing, screening tools, opioid agonist therapies, and medication reviews. But I'll take a brief moment to explain what we mean by other and by therapy adjustments. So by therapy adjustments, we were just referring here to any modification to the care plan or clinical pathway. And other in this case refers to literature that fell under the domain of education, but did not really have an intervention that was specific to the ones that are listed here on this slide. So to this point, we have discussed what the research question was and what we found in terms of the interventions that were reported in the literature. And I shall just take a few brief moments to highlight the impact of the specific interventions that were identified, as well as some of the barriers that were reported in the literature. So when looking at therapy adjustments, 63% of the reported findings were statistically significant. And in this category, some of the major barriers included lack of independent authority of the pharmacists. Looking at medication reviews, 46% of the articles reported statistically significant outcomes. And here, some of the barriers included errors or omissions to the health record. Excuse me. Looking at opioid agonist therapy, 35% reported statistically significant outcomes. And some of the barriers that were cited here included the perceived lack of need, either by the patient or by the prescriber. Looking at screening tools, 86% reported positive outcomes. And some of the challenges here included universal implementation, as well as the perspectives of patients and the pharmacists. Looking at academic detailing, 67% reported statistically significant outcomes. And some of the major challenges in terms of barriers cited here included time constraints on the part of the pharmacists. And lastly, looking at this category other, 50% reported statistically significant outcomes. And some of the major barriers here included sample size, as well as follow-up with regards to, or rather completion of follow-up surveys. So looking at what we've just discussed today, we're able to identify 6 major interventions that pharmacists have been doing with regards to opioid stewardship, as well as the given impact of these activities. And we're optimistic that looking at our findings, what we're able to identify, that this will be helpful in terms of providing greater context for the literature, and also hopefully will contribute to future pharmacy practice. I'd like to thank you all for your time and attention. And with that, I'll take any questions that you may have.
Thank you so much, Nyasha, for your presentation and walking us through all of the data that I know is involved in conducting a scoping review. I don't see any questions in the chat box yet, but maybe from my perspective, what do you see as some of the next steps? I think this scoping review provides a lot of really important findings about what if some of the positive outcomes are, and also what some of the barriers are. So just curious what you and your team see as next steps in terms of carrying this work forward, or through knowledge translation and dissemination to project partners.
Absolutely. Thank you for that, Annalise. That's a great question. So part of the big picture, I can't disclose too much, but part of what we're working on doing for our next steps is to establish a consensus framework where we then look at the major findings of this review and develop recommendations that can then be forwarded and really be an instrumental piece in terms of actually turning these findings into practical next steps for change at the level of pharmacy practice. So that's a big picture summary of what we're looking to achieve at the next stage.
Yeah, that's very exciting. Thank you. We'll definitely stay tuned for that. And I can see from Diane and Zahava, you've got some accolades for your presentation. So thank you so much.
Thank you so much for your time.
Yeah, I'm now going to turn it back over to Sherilyn, who will introduce our next oral research presentation. Thank you.
Thanks, Annalise, and thank you, Nyasha, for your excellent talk this afternoon. Our next presentation is going to be provided to us by Lisa Bishop. Dr. Lisa Bishop is a pharmacist and associate professor in the School of Pharmacy at Memorial University. She teaches in the area of chronic pain and provides clinical pharmacist services at an academic family medicine clinic where she helps patients manage their chronic pain. She conducts research in the area of opioid stewardship, substance use, and cannabis. She is co-leading a study exploring the perceptions of pharmacists on the barriers and facilitators of providing opioid stewardship activities in pharmacy practice. Dr. Bishop will present to us today on the pharmacist's role as opioid stewards using the CDSA exemptions, a qualitative study. The stage is all yours, Lisa.
Perfect, thank you. I'll just share my screen. Okay, well, thank you for that introduction. So I just want to talk to you about this study that we've conducted over the past several months on looking at the pharmacist's role as opioid stewards using the exemptions that did come into effect because of COVID. And I just want to highlight the research team that we worked together, obviously, to do this work. So they are acknowledged here on the slide. And in terms of disclosures, this work was supported in kind through CPHA, so they did support us. And at the time of the work, both Sahava and Shelley did work with CPHA as part of the disclosure for this work. So I just want to talk a bit about the definition of opioid stewardship. So as you know, pharmacists have a key role to play in opioid stewardship. And there are some differences in definitions of what that actually means. So just to introduce the definition that ISMP Canada uses, which I really like, they state that opioid stewardship is the coordinated interventions designed to improve, monitor, and evaluate the use of opioids in order to support and protect human health. So I think that's a nice, concise definition of what we're trying to accomplish. And if we look at the exemptions that were put in place, they covered several different areas, and they began in March at the beginning of the pandemic, basically recognizing that patients needed access to their medications, and in particular because the exemption or the Health Canada didn't allow for pharmacists to prescribe opioids. That's why these were enacted. So they covered the pharmacists being able to extend and renew prescriptions, transfer prescriptions to other pharmacies, deliver the controlled drugs to patients, as well as accept verbal orders. And the next slide here is a nice table that CPHA has put together that shows the differences of how these exemptions have been used across the country. So as you can see here, not everybody has enabled the pharmacists to use them provincially within their own jurisdictions, and this outlines how they have been used. And I just want to highlight the part here about the adaptation that wasn't directly through the exemptions, but indirectly it allowed pharmacists to adapt the opioid and controlled drugs. So I'll just go into a little bit about our study that we did. And really it was all about determining or exploring the perceptions of pharmacists on the barriers and facilitators that they encountered of providing opioid stewardship through using the exemptions. And we did qualitative interviews with pharmacists from across the country. We did receive ethics approval. And we interviewed both community or primary healthcare pharmacists who did use the CDSA exemptions to manage opioid therapy. We de-identified all the transcript, and we did use pseudonyms. So later on, when you see some names, they aren't people's real names. And then we did semantic analysis to identify themes. So I'll talk about those now in a second. So just to give a sense of who we spoke to, we had a total of 20 pharmacists that we spoke to, and they range from kind of more junior pharmacists to more senior pharmacists, both in rural and urban practice, and across a variety of practice settings. We had a good array of pharmacists that we did speak to. We did have representation from all 10 provinces, but we didn't have anyone from the territories. And this is just a word cloud that we put together from the transcripts, and listening to all the pharmacist stories from across the country was wonderful. So there's so much rich information that was shared. And you can see just here from this word cloud that the patient was at the center of the interview. So that's always at the forefront. So I'm first just going to give you a few examples of how the exemptions were used, and then I'll talk a little bit about the themes. So these are just a couple of examples that I pulled out. So for a verbal order, for instance, on the evening or a weekend, the pharmacist would have to call the prescriber to get a prescription for OAT. And I did find very commonly, there was a lot of examples around OAT in terms of needing the use of these exemptions to help those patients. But again, it was also for other reasons as well in terms of other pain management. There was an instance where one patient didn't want to travel to the pharmacy because the pharmacy was an area where there was a lot of outbreak of COVID, a lot more cases. So then they had the prescription transferred closer to home so they didn't have to encounter that area. There was a patient with hip surgery and couldn't get to the pharmacy very easily. So the pharmacist was able to get that medication delivered to the patient so they didn't have to go out. There was a cancer patient who ran out of their opioids over the weekend and the pharmacist couldn't reach the prescriber. In the past, the pharmacist was pretty much, their hands were tied because they would either have to send the patient to the emergency room or the patient would have to go without. But in this case, the pharmacist was able to extend the prescription until Monday and until they could reach a prescriber. An adaptation has been used to, this example here was, there was a prescription for an opioid for dental pain with a large quantity. So then the pharmacist felt the need to work with the patient and reduce the quantity so they didn't have as much opioid at home. And the themes that came out from all the transcripts and our analysis we're divided into three main themes. So patient care, the impact of the regulations, and awareness and education. And for patient care, the continuity of care was one of the big things that came out and the ability of the pharmacist to provide that. It also, a sub-theme under that was around collaboration. So the importance of collaborating with the other healthcare professionals was so important. And also the scope of practice of the pharmacist was another thing that came out under the patient care theme. And in terms of the regulations, a few things around the, I guess, day-to-day operational and administrative considerations, as well as a lot about congruence and scope and consistency across jurisdictions and providing that equitable care for patients. And then awareness and education for the patient, the pharmacist, and other healthcare providers was the other theme. So I'll just give you a couple of quotes before we finish, just to demonstrate what some of the participants said about that came under these different themes. So Carlos said, "We had to send the patient to the emergency room to get their prescription renewed, but we know those patients better than the emergency room doctor. So now we are able to avoid that type of problem because most pharmacists know their patients very well when they are a chronic pain patient." So I think that speaks very nicely to the continuity of care that pharmacists are able to provide. Tracy emphasized the importance of education, and they said, "I think that continued movement towards providing more education would be big, because I think the biggest gap is probably the education of all healthcare team members, as well as the public, to try and reduce stigma related to opioid use disorder management." And Gilles talked about the differences of how the exemptions have been enacted across the different jurisdictions. So they said, CDSA exemption came out. The hindering is the activation of, because there was quite a bit of gap between what Health Canada said and what could be implemented in each of the provinces. So just, I guess the conclusion from this work is, I think that the pharmacists demonstrated that they can appropriately and safely manage opioid therapy. And it really has facilitated the pharmacists being able to help with the patient's continuity of care. And this work can really be used to help advocate for the pharmacist's role in providing opioid stewardship. And these exemptions do expire in the end of September. And this is, we really need to consider how to implement these permanently, as well as have consistent implementation across all the provinces and territories for equitable access to patient care. So I'm just going to close with this quote that John shared with us. For all the changes in policy during COVID, I think the CDSA exemptions have been, at least from my point of view, by far the biggest, most impactful thing. So I'll open it up to questions now.
Thank you for that, Lisa. We'll see if anyone can pop in some of their questions into the chat box. Maybe just to get us started, I really liked how you closed with just looking at some of the different jurisdictions. What, in your opinion, do you think will be some of the biggest factors in making this permanent moving forward? Like some of the biggest factors, I guess, from your research.
Yeah, so I think one is that pharmacists need to demonstrate that they can responsibly be a core member of that healthcare team and responsibly manage opioids and controlled drugs. So I think that's one thing that will help our case, and this work helps support that. Because if we can show that we can be responsible, then the government should be more comfortable in allowing us to expand our scope in that regard more permanently. So beyond the pandemic. And it's interesting when we listen to the stories from the pharmacists, there's lots of stories in relation to the pandemic and the need to use these exemptions to provide care to the patients, but it went beyond that. So there's a lot of examples that the pharmacist was now able to use these exemptions in order to provide care outside of the pandemic. So that has been helpful as well.
Mm-hmm. Yeah, thank you for those. And I think I also really liked how you touched on advocacy, and I think just strengthening the voice of the role of the pharmacist throughout. Actually, a couple of questions are coming in, and I think we still have a few minutes. So maybe from Jim, I'll ask this question first. Are any quantitative data being published on actual interventions that frontline pharmacists have had the courage to implement?
So are you, Jim, talking about specifically around the CDSA exemptions and using them, which I'm assuming that's what you're referring to?
Yes.
Not that I'm aware of. So our work was done, the qualitative work. I don't know if there was any quantitative data collected on that, but that I think is one thing that would be very interesting to capture more broadly, say in a survey type of methodology to see how broadly it has been used and how much it has been used, and even looking at the provincial differences, because that was common talking to pharmacists from the different provinces and how they've been able to use the exemptions and how some have been a bit more limited because of the ability of what they've been allowed to do.
Thank you. And I'll also ask Catherine's question, which is, I've seen some missed opportunities for using CDSA exemptions through my practice at a FHT or family health team, with some patients unfortunately going into withdrawal. Are you planning any research, or maybe do you know of any research into the uptake by pharmacists throughout the pandemic? So I guess more assessing how pharmacists have taken this up throughout the pandemic.
Yeah, and I guess that ties back into Jim's question too, in terms of looking quantitatively. And I think there's a few things that came up even from our work is some of the barriers in terms of one, working into your workflow. So how do you work it in, and are you comfortable doing that? So that's why that education theme came up, and pharmacists were a sub-theme under that, because some of it is just the comfort level and recognizing how they can do it and being confident to be able to use the exemptions. And some pharmacists were even reluctant in terms of implementing this, knowing that it's going to be, it's not permanent. So you work this into your workflow now, and you do this for your patients, but then in a few months' time, you have to turn around and say, well, I can't do that anymore. So that there have been some limitations limitations around that for sure.
Thank you for that. And I think Philip just has a comment to kind of close this off. Unfortunately, there may be administrative requirements that impact being fully able to use the CDSA exemptions. For example, the need for pharmacists to document why there is a need for more frequent dispensing and how this may inhibit a pharmacist from reducing quantities dispensed. So,
yeah, so there are definitely some barriers that need to be worked out in terms of logistically, and that's why there is that other sub theme around those kind of operational administrative considerations and how do you best navigate those.
Great. Well, thank you so much, Lisa, and thank you as well to Nyasha and Tara for getting the first hour of today's summit started. I'm going to bring us back in 3 minutes, so we'll take a quick 3-minute break just for people to maybe grab another cup of coffee or water, and we will get started back here with Sherilyn and myself to introduce the second half of the oral research presentations for the day. Thank you, everyone, and we'll be back shortly. Okay, so welcome back, everyone. I think we're going to go ahead and get started with the second half of our schedule for today. So I will turn it back over to Sherilyn, who will get us started with some more introductions for our next presenter.
Thank you very much, Annalise. Welcome back to the second half of our session today. So I am pleased to introduce to you now Lesley Graham. She trained as a pharmacist in the UK, where she worked for several years in the areas of hospital formulary management and academic detailing in primary care. She is interested in the role that pharmacists can play in the rational use of medications, notably prescription opioids in acute pain. She is currently a graduate student at the Center of Addiction and Mental Health and the University of Toronto. Her presentation today is an intervention to promote opioid stewardship in acute pain by community pharmacists in Ontario. Over to you, Lesley.
Okay, thanks everyone. Sorry, just put my camera on there. So thank you for the kind introduction. As Sherilyn said, the title of my presentation today is an intervention to promote opioid stewardship in acute pain by community pharmacists in Ontario. This is an ongoing study, and the co-leads are Beth Sproule from CAMH and University of Toronto, who's also our discussant today, and Sylvia Hyland from ISMP Canada. It's been funded by Health Canada, and I have no conflicts of interest to declare. So why is opioid stewardship in acute pain important? Well, studies have shown that opioids are prescribed excessively in acute pain, leading to significant quantities of leftover tablets in the community, which can be diverted for non-prescribed uses because we know they're not stored and disposed of appropriately all the time. And they can also cause harm as well. But it's not just the leftover tablets we have to worry about. We also know from studies that using opioids for an episode of acute pain can lead to long-term use in some people, and it's associated problems such as cardiovascular events, endocrine dysfunction, and the development of an opioid use disorder. One of the main risk factors for this is the duration of initial use of the opioid, which is why excessive quantities can be a problem here. The good news is, though, that studies have shown that these quantities can be reduced without negatively impacting pain management. So what's Ontario doing to improve opioid use in acute pain? Well, in 2018, Health Quality Ontario published a quality standard on opioid prescribing in acute pain for the over 15s. And this includes recommendations around place and therapy of opioids and durations of use and safer daily doses, and promotes the counselling of safe storage and safe disposal. In addition, the Cut the Count initiative works with hospitals to promote the use of smaller quantities of opioids in acute pain after surgery on discharge. So the medical community are taking action here. However, it will take time for prescribing culture to change across all acute pain settings and prescribers. And this is where community pharmacists can actually play a role, because they are exposed to a wide range of prescribers, and they have the ability within their scope of practice to, for example, dispense smaller quantities if appropriate, and provide guidance to patients on staying within a safer maximum daily dose, and counselling on safe storage and safe disposal. So this is where our study comes into play. The objectives of our study are were to design an intervention using HQO recommendations to provide community pharmacists with the capability, opportunity, and motivation to incorporate enhanced opioid stewardship activities into their practice for acute pain. For example, dispensing smaller quantities if appropriate, providing guidance to patients on staying within safer daily doses, and providing counselling on safe storage and safe disposal. The second objective was to evaluate if this intervention does impact the capability, opportunity, and motivation of community pharmacists to incorporate these practices I've described. I should say that this study is part of a bigger randomized control trial where we will be looking at the quantities of opioids dispensed by community pharmacies in 5 randomly selected public health unit regions of Ontario, and comparing those quantities with that dispensed by 10 matched control public health unit regions. So before I talk about the design of our intervention, we did want it to be scalable, which that means that it could be rolled out across the province and country. We wanted it to be flexible so that pharmacists working shifts with families, etc., could access it at their leisure. And we wanted it to be equitable, so there was equal access for pharmacists working in remote regions. So we decided we wanted to design an asynchronous online intervention, and this was pre-COVID-19. In terms of the intervention design, because the goal of the intervention is to change the way that community pharmacists dispense and counsel on opioids and acute pain, we look to the behaviour change literature for healthcare professionals. And this suggests applying a theory when designing your intervention, and we use the capability, opportunity, and motivation of theory of behaviour, which states that for a person, or a pharmacist in this case, to perform a desired behaviour, they need to have the capability, opportunity, and motivation to do so. Next, we identified barriers and facilitators to the changes that pharmacists needed to make to perform these desired behaviours. And we did this by looking at the pharmacy literature around barriers to kind of scope of practice changes, etc. But we also made our barriers context specific by working out how these changes would be made in a pharmacy at the operational level and looking at barriers to specific steps in the process. We then mapped these barriers to factors influencing behaviour change using the theoretical domains framework and the COM-B tool. And then we selected intervention components to overcome these barriers. And if you look at the first table here, one of the barriers we identified was lack of awareness by pharmacists of recommended opioid quantities for acute pain. We decided that this was a knowledge issue, and the way we overcame it was by information provision through e-learning modules. And I should say at this point that HQO recommendations around quantities were in durations of use, and we took a lot of time to translate that into what would be a reasonable quantity for a pharmacist to use in practice. So we also developed a quantities reference tool for them to use kind of at their fingertips when in everyday practice. So because the majority of our barriers related to knowledge and skills, a big component of our intervention was education through e-learning modules. So we developed 5 e-learning modules, and initially the first module was all around kind of motivating the pharmacists to take action here, like why is this a problem? And the next 3 modules were really around giving them the knowledge and skills to take action on these issues. That is their capability. And lastly, we pulled everything together by, because although the majority of our barriers were around knowledge and skills, we also dealt with ones around a kind of opportunity and motivation by providing implementation tools to help them implement these changes in practice or create an opportunity for them to do so in their everyday practice. So this is just to show you what we developed. On the left is a screenshot from our e-learning modules. In the middle are 2 of our implementation tools. The first one is around the quantities reference. It shows pharmacists how to define if a quantity is excessive and then what a reasonable quantity would be to suggest to a patient. We also developed a checklist for, to remind them of questions that they need to ask to make it easier for them. And on the right-hand side are the communication or patient-facing tools, which we developed with a patient representative. The poster is to display their practice, and the handouts to make it easier for them to discuss these issues with their patients. And the kind of last step before launch was usability testing. So we did this in collaboration with human factors engineers who had advised us on sample sizes and design, etc. And we had 4 pharmacists test the e-learning modules. The feedback was positive, and all pharmacists strongly agreed that they would change their opioid dispensing practices after viewing the modules. We also tested the communication tools with 4 patients using mock scenarios, and again, the feedback was good. So after tweaking our kind of intervention, we were supposed to launch in March 2020, but because of COVID-19, we delayed that, and we did actually launch in September 2020. We emailed 1,560 community pharmacists working in our 5 randomly selected public health unit regions, and we also e-faxed those pharmacies as well. We gave them an invitation to undertake the intervention, that is the modules, and also undertake surveys as well. And recently we've been providing webinars in the evening to community pharmacists in those PHUs to increase uptake as well. In terms of our evaluation, we're undertaking 3 surveys. We have a pre-module survey for kind of baseline data, post-module surveys for after they've undertaken the modules, and we're developing a post-intervention survey just now. And our surveys are designed to evaluate the capability through kind of questions around knowledge and skills, motivation, that is their intention to undertake these desired behaviours which we're suggesting in our modules, etc. And asking questions around opportunity after the modules, like are there still any barriers to you actually doing this in your practice? So our numbers are small just now in terms of our results. So really today, I'm just going to give you a flavour of, well, I can't draw any conclusions yet, but I'm just going to give you a flavour of what we've seen so far. So in terms of capability, in terms of the knowledge piece, 100% of our participants knew the maximum daily MME dose post-modules compared to 47% pre-modules. 83% of participants knew the recommended duration post-modules versus 74% pre-modules. In terms of skills, 93% could identify an excessive quantity post-modules compared to 79% pre-modules. 93% could identify an inappropriate formulation post-modules compared with 85% pre-modules. And 77% after the modules felt confident discussing a part fill with patients versus just 55% pre-modules. In terms of our opportunity, in the post-module survey, 40% of the participants still anticipated barriers even after viewing the intervention and seeing our tools, etc. And 12 of these participants actually gave us feedback as to what these barriers were, and these included lack of time and patient attitude being the main ones. And these are barriers we did actually pick up in our initial review of the barriers and facilitators. In terms of motivation, almost all participants, both in the pre and post-module survey, felt it was important as a pharmacist to be involved in opioid stewardship and acute pain, and they also felt it was important to assess opioid quantities. We noticed there was some increase in confidence in recognising maximum daily doses and quantities after viewing the modules, but we did notice there was a kind of lower confidence in actually taking the steps to manage these problems that they'd identified. In terms of intention, in the post-module survey, 77% of participants will frequently or always offer a smaller quantity, and that's compared to 24% who define themselves as doing this pre-modules. 97% will frequently or always counsel on safe storage and safe disposal, compared to 69%, again, defining themselves as doing this pre-modules. In terms of reaction to the intervention itself, like what was the feedback, 90% strongly agreed they were engaged, that they'd gained knowledge and skills meaningful to their practice, and that they would be able to apply what they had learned as well. They would recommend the modules to others, which was good, and 90% strongly agreed that the cases within the modules gave them ample opportunity to practice their clinical skills. So to summarize, we really tried hard within the kind of confines of an asynchronous online intervention to provide community pharmacists with these kind of key ingredients of capability, opportunity, and motivation to undertake these stewardship activities in their practice. The intervention itself has been received positively, but our survey numbers are small so far, so we're continuing to collect data. So thank you, everyone. And just while we're taking questions, I just wanted to put this, I didn't talk a lot today about how we're also promoting pharmacists discussing the, shared decision making and the benefits and risks of opioids with patients, but we are promoting that as well. And this kind of quote just describes how important it is for pharmacists to have that conversation with patients. So thank you very much, everyone.
Thanks, Lesley. Thank you for that. And thank you for leaving us with this quote. Maybe you can leave it on the screen so that people can read it, but I think it's quite compelling. Just wanted to address a comment, I think Anne online, sorry, my chat box, she just said addressing motivation might include regular positive or supportive, i.e. encouraging messaging by regulators. So I don't know if you want to expand on that at all. I know you touched on it in the results there.
Yeah, I mean, it's interesting because when you look at the survey results, pharmacists really do want to kind of get involved here, and that definitely comes out as well. And I know it'll be interesting to see what OCP does with their. What we did actually in our last communication to our pharmacists was we gave them some feedback around the OCP quality indicator around dispensing within 50 MME per day to see whether that would kind of motivate pharmacists to kind of relating it to their LIN and to say, oh, so many people in your LIN are still actually getting doses greater than 50 MME per day to try and kind of motivate. I think it's true that some positive from the college or whatever as well to just you really encourage pharmacists to get involved here as well. I mean, it's even from the usability testing, it's really interesting the different comfort levels of even just within those 4 participants. Some were just raring to go at the end, and then other ones were, you know, slightly more reticent, just, you know, their comfort level was different. So every pharmacist is very different here. So
thank you for that. I'll also just read out another, more of a comment, I guess we have. As a pharmacist, I try and minimize initial day supply using the Ontario Surgeons or HQO guidelines. There were 2 barriers that I noticed in practice. Number 1 is information regarding the procedure and recovery time to assess duration of therapy. Number 2, part fills mean that patients have to pay dispensing fees twice, as you mentioned, which increases the cost of the medication. So many patients prefer to get the whole quantity dispensed once.
yeah, so I mean, what we worked really hard to try to translate that duration of use recommended by HQ into an actual reasonable quantity that a pharmacist could quickly just access when they're actually making that decision around a quantity. So we did a lot of work on that. Actually, best practice surgery in Ontario is actually just released, and it was actually March 2020, guidance looking at specific quantities after specific types of surgeries. So that's very much more specific. If the person commenting, you know, that's a good place for them to look. But it still does require, you know, asking the patient questions. The patient might not always be there. It might be a fax prescription. So there definitely are barriers, and we really tried hard within the context of this intervention to kind of present what these would be within a case and how we could overcome them. But yeah, it's definitely difficult. And the second dispensing fee comes up, you know, has come up, and it's definitely a judgment call on the pharmacist. And we actually included that in our handout. It was to make sure that patients would be aware that they may have to pay us the second dispensing fee if they have to come back and get more tablets. Yeah. But the good news is, when you look at the studies, so a tiny amount of patients actually need a second supply. Not many.
Yeah, thanks for that, Lesley. And I can see Alice has popped in a consensus statement for the prescription of pain medication at discharge after elective adult surgery. So another resource there for people. So thank you so much for your presentation, Lesley. Absolutely fantastic. I will pass it over to Sherilyn to keep us moving along with our research presentations. Thank you.
All right, thank you very much for that very engaging presentation. And thanks again, Annalise, for keeping everything on track. So I'd like to introduce our next speaker. So Dian Yu is currently a 4th-year pharmacy student at the University of Waterloo. Her current research, under Dr. Fen Chang's supervision, focuses on pharmacist interventions in chronic pain and the effect of visual aids on medication adherence. Her presentation today is on a systematic review on the effectiveness of community pharmacist interventions in chronic pain. Over to you.
Thanks for that kind introduction. Can everyone hear me okay?
Yep, sounds good, Diane. Thank you.
Thank you. Thank you everyone for being here today. Welcome to the presentation on the effect of community-based pharmacist interventions in chronic pain, a systematic review. I'd like to give a big thank you to Professor Feng Chang, as well as my co-reviewer Hung Nguyen, and our librarian Caitlin Carter and Huda Shah for their phenomenal support. This study was funded in part by Health Canada's Substance Use and Addictions Program. The views expressed therein do not necessarily represent the views of Health Canada. I also declare that I have no affiliation, financial or otherwise, with a pharmaceutical, medical device, or communications organization. So brief introduction, an estimated 1 in 5 Canadians live with chronic pain. Furthermore, the pain experience is often not controlled. So 2/3 of Canadians are living with chronic pain, have moderate to severe pain. It is well documented that multidisciplinary pain clinics are the gold standard in the treatment of chronic pain. So as medication experts, pharmacists can play an important role. However, current guidelines regarding interdisciplinary teams do not always mention the role of pharmacists. And for many Canadians who are on a wait list to get into these specialized pain clinics, community pharmacists are able to do much more, but are currently underutilized. So this brings us to our research question. The purpose of the systematic review is to assess the effectiveness of pharmacist interventions on ambulatory, chronic, non-cancer pain patients. To answer this question, we briefly highlight our methods. With the assistance of our librarian, Caitlin, search terms relating to pharmacy and chronic pain were developed. We searched 5 databases: Embase, Cochrane, International Pharmaceutical Abstracts, SynHall, and PubMed. Our literature search results were uploaded to Covidence, an internet-based software program, and 2 reviewers independently screened all the articles against the inclusion criteria. Conflicts of decision were resolved through discussion, and using a standardized forms, the 2 reviewers also independently extracted data for each eligible study. To measure the effect of pharmacist interventions, the primary outcomes we looked at were patient-related outcomes like pain, quality of life, and patient satisfaction. We also wanted to look at negative outcomes, so we looked for the cost of running the pharmacist intervention and any adverse drug reactions they may have as a result. In our study, our secondary outcomes focused more on the administrative side, so things like team efficiency or improvements in teaching or administration. Our inclusion and exclusion criteria is summarized in this table. So we included randomized controlled trials and observational studies, but we excluded cross-sectional studies, case series, and case reports. All ambulatory locations were included. So we did include community pharmacies, as well as family health teams or chronic pain clinics. However, patients in hospital or long-term care homes were excluded. Only studies in English were included, and any interventions including a pharmacist, whether it was pharmacist-led or the pharmacist only played a role, were included. Patients had to have chronic pain defined as pain lasting for more than 3 months, but cancer pain patients were also excluded. So what did we find? Our research resulted in 2,582 studies, and in the end, we included 32 studies. Of those, 21 of them, or 65%, were on the effect of pharmacist-led interventions, and 35% were on multidisciplinary interventions, which included a pharmacist as a team member. Next, I'll share a bit about the demographics of the included studies. So here's a distribution of studies by the study design. The most common study type was a prospective observational cohort study, which accounted for 46% of all studies. 6 studies, or 12%, were randomized controlled trials. Here's a distribution by study follow-up length. The most common amount of follow-up was 6 months, and 84% of the studies had a follow-up of less than 1 year. Most of the studies had a small population of less than 400 people. Hence, there's a lack of large population studies. The reasons for this may include the size of a multidisciplinary pain clinic or a community pharmacy may not include that many patients. Another reason may be a result of the short follow-up time, which doesn't allow much time to enroll more patients. Other than one study in Japan, all the studies were in English-speaking countries like the USA, Canada, the UK, and Australia. The majority, or 53%, were in the USA, but Canada was second most common, with 21% of the studies in Canada. Before we get into the data examining effectiveness, we want to understand broadly what pharmacists are doing. So we went through every study and compiled a list of all the roles and all the interventions that pharmacists were performing. We then went through and found that they fell into 4 main categories. So those are medication review, clinical interventions, policy and administration, and follow-up. Most people here are probably very familiar with the medication review. In addition to verifying the current medications taken by a patient, you ensure the indication, efficacy, safety, cost, and convenience of all the medications. Secondly, pharmacists can perform clinical interventions such as developing care plans, providing education, recommending medications, overseeing tapers or inductions, or prescribing where applicable. Thirdly, pharmacists can play a role in designing and prescribing or dispensing policies, as well as policies for different healthcare systems or for the family health team where they're working. They can also be a member of a review team, which was done in some studies where the pharmacist and physicians on the team review current things the prescribers have done and make recommendations. Thirdly, pharmacists can also play a role in a large role in follow-up with the patient. Pharmacists have a good understanding of side effects, so they are able to arrange follow-up visits, answer follow-up questions, and where applicable, they can order and interpret follow-up tests. For example, an ECG for methadone monitoring or urine toxicology tests in opioid patients. So all of these interventions are things current pharmacists can do, but may not be currently asked to do. So should we encourage pharmacists to do these interventions more? Were they effective? We found that pharmacist interventions positively impacted pain scores and quality of life. So pharmacist interventions alone showed significant improvement in patient pain scores, and the quality of life scores in patients improved, but were found to not always be statistically significant. So 4 studies looked at the quality of life in pharmacist-led interventions, and 2 studies showed non-significance. This may have been because the 2 studies that showed non-significance had only a follow-up of 3 months. Studies that demonstrated significance had a follow-up time of at least 6 months. Additionally, the randomized controlled trial by Brunn et al. Showed that there was a decrease in the quality of life in the control group, but an increase or staying the same in the intervention group. So even in studies where there is no improvement, that doesn't mean the intervention is not working. Perhaps the group may have decreased functioning without the treatment. So that is why controlled trials, as well as trials with longer follow-up, would be beneficial. In terms of cost, pharmacist interventions were found to be more cost-effective than usual care. One cost analysis of a randomized controlled trial conducted in Vancouver, Canada, found that a community pharmacist-led education and referral initiative resulted in ICERs, or incremental cost effectiveness ratios, of $232 per quality of life year gain from the Ministry of Health perspective, and $14,395 per quality of life year gain from the societal perspective, compared with usual care. We wanted to highlight this study because it was very strong and it was set in Canada. In addition to being a randomized controlled trial, it calculated the cost in both the societal and Ministry of Health perspectives. Another study found that compared to a physician only versus a pharmacist-physician treatment, the pharmacist-physician dual treatment approach was actually 13 times less expensive. In community pharmacies, we also found that in all community pharmacies, pharmacist interventions reduced wait times. So in community pharmacies, pharmacists are already accessible and part of the circle of care. Hence, any interventions the community pharmacist could do would be reducing the wait time of the patient to be admitted to a chronic pain clinic or to see a specialist. In multidisciplinary clinics, pharmacists have also been shown to significantly reduce the number of visits required of the patient, to increase the access to the physicians, and to significantly increase the speed of access to a healthcare professional that can return their call and answer their question. Pharmacist interventions were also found to greatly reduce opioid risk. So there are many studies that focus specifically on chronic pain interventions in terms of opioids, and they found that pharmacist interventions statistically reduced the average patient opioid dose. They also increased naloxone dispensing, increased urine drug screening, as well as increasing the number of urine toxicology tests. They also significantly increased the signing of medication agreements and EKG monitoring in patients on methadone. So in conclusion, our systematic review found that pharmacist interventions are an effective intervention in reducing pain scores in chronic non-cancer pain. Pharmacists are also a cost-effective solution to reduce wait times, and pharmacists can provide opioid risk interventions and monitoring. Some possible future directions that might be looked into further. In Ontario, allowing pharmacists to order and interpret lab results may allow pharmacists to play a role in opioid and pain medication monitoring. Additionally, financial support of pharmacists who monitor patients with chronic pain medication may reduce barriers to pharmacist follow-up. And for future research, more controlled studies with a larger population and longer study duration would be beneficial. Thank you so much for listening to the presentation.
Thank you, Diane. Thank you for that great presentation and great overview of work. I think it's so encouraging how nicely your results and kind of your work is meshing with the other presentations that we've heard today. And I also thank you for leaving us with those kind of next steps and next directions, which I think really strengthen the role of the pharmacist and back to that kind of advocacy piece. So thank you so much. Just in the name of time, I'm going to keep us moving along, but I'd like to encourage everyone online to submit any questions they might have for Diane or about her presentation just into the chat box. But thank you again, Diane, and I will pass it back to Sherilyn, who will introduce our final research presentation of the day.
Thank you.
Thanks so much, Dan. So our last research presentation today is a joint effort. So I have three individuals to introduce for this. So first I will introduce Alice Watt. She is a senior medication safety specialist with the Institute for Safe Medication Practices Canada and has experience as a pharmacist in community and acute care settings. Next, Dr. Susan Sutherland is an associate professor in the Faculty of Dentistry at the University of Toronto, and until recently was the dentist-in-chief at Sunnybrook Health Sciences Centre. Her clinical practice has focused on patients with medical complexity, while her academic interests include antimicrobial stewardship, opioid use and misuse, and the design and implementation of virtual care in hospital-based dental practice. Finally, Amy Ma has been a patient public advisor with Choosing Wisely Canada since 2018. She is also involved with organizations such as the Montreal Children's Hospitals Family Advisory Forum, the Patient Advisors Network, and L'Appui Montreal, which provides caregiver advocacy. Her interests include maternal health, diversity and inclusion, and health equity. The presentation today is entitled First Use Non-Opioids, Managing Pain After Wisdom Teeth Removal and Interprofessional Collaboration. Over to you.
Thank you, Sherilyn. It's truly a pleasure for us to be presenting here today at the Open Summit. The incredible Helen Keller said, "Alone we can do so little, together we can do so much." And this describes perfectly our interprofessional collaboration together. The partnership between Amy, Susan, and I from three organizations, Choosing Wisely Canada, the Canadian Association of Hospital Dentists, and ISMP Canada has been synergistic and has helped us achieve a greater impact than we could have alone. And so today, we'd like to share with you our work to encourage patients to first use non-opioids as a way to manage pain after wisdom teeth removal. Amy and Susan have nothing to disclose, and for myself, I do work at the ISMP Canada, which does receive funding from collaborating organizations such as CPSI and HPSA, the Health Product Stewardship Association, a nonprofit organization representing producers of consumer health products in Canada to disseminate information about medication returns programs. I would like to now ask Amy Ma to share her experience.
Okay, so first I wanted to share with you my story. So about 2 years ago, my eldest child had his wisdom teeth removed. And after the surgery, the surgeon's assistant advised me to give my son some Percocet so he could stay on top of the pain. And with my work as a patient advisor for Choosing Wisely, I was surprised to be offered something so strong right off the bat. And I asked what alternative there was, and the assistant suggested acetaminophen with codeine, which still seemed too powerful. And in the end, our son took the pain reliever naproxen once the anesthesia wore off, and he didn't ask for anything stronger, nor was he in an incredible amount of discomfort. So next slide. Alice, can I have the next slide, please? So I had my reasons for being concerned. A teenager's brain is still developing and highly susceptible to the impact of opioids. Leftover opioids are tempting for teens to experiment with or to share with friends. Dentists are the leading source of opioid prescriptions for teens, making up over 30% of all opioid prescriptions in this age group. And when adolescents do take opioids after wisdom teeth removal, they are more likely to be using opioids 3 months and 1 year later as compared to those who don't. So the casual attitude of the surgeon's assistant was unsettling, and I wanted to do something so people don't begin to think it's normal to get Percocet after every wisdom teeth removal. So the Choosing Wisely team put me in touch with Susan at the Canadian Association of Hospital Dentists to write an op-ed. And this was initially published by the CBC and then picked up widely. Over to you, Susan.
Okay, thank you so much, Amy, and it's such a pleasure to be here at the Open Summit and presenting the work that we did together. And I'm just wondering, can you see me? I can only see Amy at the moment.
We can see you, Susan. Yeah.
We're good. Okay. So just if you could go to the next slide. I'd like to present some dentist-specific data from the report published by Health Quality Ontario in 2018. And this is a snapshot of opioid prescribing in Ontario in 2016. So in this slide, we can see that 44,000 healthcare professionals in Ontario prescribed opioids. And there were, sorry, if you can go back one slide. 3 major groups prescribed opioids: family doctors, dentists, and surgeons. And in fact, dentists were the second highest prescribers of opioids. The good news is that although we know that a duration of more than 7 days is associated with double the likelihood of continued use a year later, dentists normally don't prescribe for that great a duration. Only 3.7% of dental prescriptions were for 7 days or more. And the other piece of good news is that dentists, for the most part, don't prescribe high-dose opioids. About 80% of opioid prescriptions are for Tylenol 3, and less than 1% are for high-dose opioids of over 90 milliequivalents. If we can go to the next slide. So this slide addresses new starts of opioids in Ontario in 2016, and that's defined as prescriptions for people who have not filled an opioid prescription in the last 6 months. So if we look at the bottom row on this table, about 16% of all opioid prescriptions, sorry, if we can go back a slide, about 16% of all prescriptions of opioids were for new starts. And looking at the second column from the left, about more than half of family doctors were responsible for new start opioids, a little over 20% of surgeons, and a little less than 20% of dentists. But what is very concerning is if we look at the last column, where we see the proportion of prescribers or the proportion of prescriptions from each prescriber group that were new starts. For dentists, about 75% of the prescriptions they write are for new starts. So that's pretty concerning to us. If we can go to the next slide, please. So I think most of you are probably quite familiar with Choosing Wisely Canada, whose sort of overarching theme is to reduce overuse in healthcare, overuse of tests and overuse of treatments. And one of the mechanisms that Choosing Wisely uses is the development of lists by professional societies. And there are about 80 societies in Canada that have developed lists. And these are lists of things you shouldn't do. They're not guidelines. They're simply to provide a mechanism for patients and providers to have conversations about things. So the Canadian Association of Hospital Dentists developed a list in 2018. We actually have 8 things on our list, but the first one, and I'm going to talk about it in a moment, is about opioids. I think pharmacists will be happy to hear that the next 4 address antibiotics. And then there are 3 more that are sort of more dentally specific around radiographs and, replacement of fillings and other areas where we see overuse. So if we can go to the next slide, Alice, please. So recommendation number 1 is don't use opioids for postoperative dental pain until the optimized dose of NSAIDs and acetaminophen has been used. And for each recommendation in Choosing Wisely lists, they're set up so that it's a list of recommendations with a drop down. So the drop down for opioids gives a very brief rationale and then some sources, some evidence that we've used. So if we can just go to the next slide, which I believe is Alice, but I'd just like to finish up by saying that, based on Amy's experiences, based on the literature where we know that first use in teens is highly correlated with either orthopedic surgery or with dental procedures, coupled with the fact that nearly 3/4 of dentists' prescriptions are first uses, we really wanted to look at wisdom teeth and opioids. And so that led to a collaboration Amy and I had started. It led to further work with Alice, which Alice is going to talk about now.
Thank you so much, Susan, for giving us the background, and for Amy for sharing your experience. So I'm going to go back a little bit to sort of the background of our handout that we worked on together. It started with the 5 questions to ask, which was developed 5 years ago and involved patients right from the start. It was an initiative to encourage patients to ask questions about their medicines and to spark a conversation about medications, especially at transitions of care. It's since been translated into 30 languages and over 200 endorsements from organizations around the world. And last week, you heard my colleague Melissa Sheldrick share about the 5 questions for kids, the junior edition. And so what happened was in 2017, we used that framework to address the concerns about opioids for pain and surgery. We learned patients were taking opioids for far too long, and they had leftover opioids that they didn't know what to do with. And you've heard from many speakers today about this already. These leftovers could be used inappropriately. And so again, we worked with and partnered with many organizations and patients to create the Opioids for Pain After Surgery that has been endorsed by the U of T Best Practices in Surgery, the Canadian Association of General Surgeons, the Canadian Orthopedic Association, and many others. It's very important for me that our patient handouts be concise, use pictures along with the use of plain language, and as Dr. Gomes said, non-stigmatizing language. The handout was also used in this study by Dr. Sandro Srikandaraja and Jenny Chu from North York General Hospital for post-API and cholecystectomy patients. And it showed that using a standardized prescription along with patient education could result in a 56% decrease in the number of opioids prescribed in 3 months without adversely affecting the person's pain score, and resulted in the patient taking less opioid. As well, patient education increased to 44%. About that same time, we worked with North York General Hospital. The article that Amy and Susan wrote caught my attention, and I wondered if we could do something similar to help patients manage dental pain. I connected with both of them, pitched the idea, and they both readily agreed to work with me. I met with Amy over donuts when she came over to Toronto during March break, and we worked on the content of what would have been helpful for her and her son to know. Amy was instrumental to helping us with the words, first try non-opioids, because that's what worked for her son. Once we were able to develop the content and have it reviewed by dental experts like Susan and others, Susan helped us connect with all the various national dental associations and federations and provincial regulatory colleges for their review of the handout. And it was her leadership and influence that helped us get the support from these organizations. We also included information about storage and disposal, and we recently received this heartbreaking consumer incident report, which I would like to read for you. My father was prescribed Tylenol 3 from a dentist after a root canal procedure. He used 2 to 3 tablets as prescribed after the procedure and kept the leftover tablets in his cabinet. About 6 months later, he started having shoulder pain and took some Tylenol 3s that night. He told my mother that this had finally helped his pain. During his sleep, my father suffered a massive heart attack and passed away. If the Tylenol 3 was not taken, perhaps he would have recognized the symptoms of a heart attack. This error may have been prevented if it were emphasized to him that any leftover Tylenol 3 tablets should have been returned to the pharmacy for safe disposal. This story highlights the importance of these key safety messages that we need to share with patients. We've also worked on getting this disseminated to dentists and patients. As a result of support from the CDA, we were able to send it to 17,000 dentists through the CDA Essentials publication and sent to over 23,000 consumers on social media and through our Safe Medication Use newsletter. We've also since developed other resources that you can find on our website at opioidstewardship.ca that includes OAT resources for methadone and buprenorphine. Lessons I learned from this initiative was the immense value of collaboration with patients and prescribers from the start, the importance of standardizing our patient education about opioids using plain, non-stigmatizing language, and asking patients and prescribers to help develop these key messages together. And also that we as pharmacists have a tremendous opportunity to influence and educate our patients about safe opioid use in partnership with their colleagues who prescribe them, and patients who have had lived experience can share their story to help others too. On behalf of Amy, Susan, and I, we'd like to acknowledge and thank the entire group of amazing people listed here who have helped make this initiative possible, and the Open Summit Committee for inviting us to present today. We'd really appreciate your help getting the word out about our resources, and if you have any questions or be interested to collaborate, please don't hesitate to connect with us. Thank you.
Thank you, Alice, Susan, and Amy. I think as much as it was lovely to hear all the thank yous of everyone who's been involved in your work, I would also like to thank very deeply the three of you for kind of rounding out our oral presentations for the day. I think this is incredibly important work. What really drives it home for me is the cross sections between pharmacy, dentistry, and other health professions, and having your three voices as well as the excerpt that you read aloud, Alice, is just incredibly powerful and brings attention to this incredibly important issue. So thank you to the three of you for those excellent remarks and presentation.
Thank you very much.
Yeah, I would like to invite everyone to maybe follow up with Alice, Susan, and Amy in the chat box. I know, Alice, you also seem to have a wealth of resources at your fingertips, so I wouldn't be surprised if you pop something else in the chat box for people to look at. But thank you for that wonderful presentation, and thank you to all of our research presentations today. I'm going to pass the microphone over to Sherilyn, who will introduce our discussant and help us wrap up for the day.
Great, thanks again, Annalise. So I'm pleased to introduce our discussant for today's session, who is Beth Sproule. Beth is a clinician scientist at the Center for Addiction and Mental Health in Toronto, jointly with the Lesley Faculty of Pharmacy, University of Toronto, where she is an associate professor and is cross-appointment to the Department of Psychiatry. So Beth, over to you.
Great, thank you. Thank you, everyone. And thanks everyone for great talks today, and really such a variety of examples of pharmacists' roles and the evidence that's out there. In the interest of time, I'll keep this short, but I guess I just want to indicate that to kind of summarize and frame what we've heard today, I just want to remind people that the topic was around tackling the opioid crisis. So just to kind of frame it with that, as a reminder that the crisis has sort of two key negative outcomes. One is the development of opioid use disorder, which is a relapsing, life-threatening disorder. And then the second is around the overdose mortality, morbidity and mortality, which also is, just want to remind you, it can occur in anyone using opioids, above their tolerance level, whether they have opioid use disorder or not. And I think that framing just kind of helps see where we as pharmacists kind of fit in helping this crisis. And just to kind of summarize what we've heard today, I thought I'd frame it according to the federal government's framing of their priorities around addressing the opioid crisis, which includes 4 areas. One is awareness and prevention, access to harm reduction, access to treatment, and the tainted drug supply. So just briefly with each of those and how they were addressed in today's presentations. Starting with awareness and prevention, I think that Tara did a good job of reminding us all of how the crisis was initiated and the role of prescription opioids in that problem. And that's where, as pharmacists, we do have a key role, and that was talked about quite a bit in the presentations today around opioid stewardship. And that really is all about preventing the harms. Of course, it has some benefits around helping improve their use in managing pain, acute and chronic pain we heard today, but also just preventing the amounts of opioids that are out there, the amount of exposure to people to opioids, and that risk of developing an opioid use disorder, as well as having the medications out there that can contribute to the overdose deaths. So I think from the variety of talks today, I think that was well highlighted in most of them, whether it was acute or chronic pain situations, around the types of activities pharmacists can do in opioid stewardship, from monitoring therapy to limiting quantities to providing education, developing great education tools to educate the public. I think that's all quite promising. I think the next area is around access to harm reduction. And this one from the government emphasizes a lot around safe consumption sites, but also around the promotion of naloxone distribution. And Tara and a few of the presentations today also highlighted the pharmacist's role. And I think a key question there is, how can we optimize that? How can we do better? In answering some of those questions that Tara raised about why aren't more pharmacies doing it. The third area is around access to treatment. And this one I'd also like to emphasize, because this really means access to treatment for opioid use disorder. And again, Tara's talk emphasized this, as a number of other talks also talked about opioid agonist therapy. And I really want to emphasize that it is the mainstay of treatment for opioid use disorder. And there's a long, strong evidence base for methadone and now buprenorphine and their role in preventing overdoses and overdose deaths. Even in the era that we now see with the tainted supply and the role of fentanyl, these still are our best approaches to treatment and to keeping people safe and alive. And really any approach that we can take, and we as pharmacists that can help facilitate that, Lisa gave examples around the CDSA exemptions, helping with accessing and continuity of care in OAT. And Tara mentioned the OAT guidance documents and the changing approaches that occurred over the pandemic. And I think all of these things are really important to evaluate and to really be able to see what direction and how we should go forward with keeping those changes, evaluating, or whether how much we need to kind of backtrack to the way things were kind of pre-pandemic and pre-fentanyl era. And the final area is with respect to the tainted drug supply. And this is, the federal government's priorities are focusing on sort of enforcement and those types of things. But this is also where you could see the role of the safer supply paradigm that was brought up in the earlier talks around providing pharmaceutical opioids as a substitution for the tainted street supply. And this could also be seen under harm reduction. It tends to not be framed as treatment, although it is tied in with primary care offerings. And so with respect to, we know that pharmacists are involved in this across the province, and I think that we as a profession really need to be involved in what will be the best, what are the best practices for pharmacists in that paradigm, as well as in advancing the other paradigms around OAT's provision of services, as well as in the prevention and in opioid stewardship activities. And then just in the final 30 seconds, I just want to finish off highlighting again that what several people have mentioned this afternoon around the issue of stigma, because this impacts all of the efforts we can do in the realm of improving the opioid crisis. It is challenging and can really impact in a negative way any of our the interventions that we're trying to implement. And so really encourage everybody to think about their own kind of perceptions and words that they use in referencing people who have substance use disorders, in particular opioid use disorder. And I just really hope all this great work continues, especially as we continue to figure out with implementations and educational approaches how we can keep moving this forward. Thanks.
Thank you so much, Beth, for those closing remarks and just giving us such a perfect synthesis of the day. I really appreciate those thoughts. And I love how you also brought it back to kind of Tara's opening slides about how important language is, and that as patients, as pharmacists, we all have a role to play in making sure that that's safe and accessible for everyone. So thank you for that. On the topic of language, thank you to all of our presenters for all of the amazing work that was shared today. We are approaching the end of our day, so I'm going to do a final pass over to Sherilyn, who will close us out. Thank you.
Thanks so much, Beth, for your thoughts on the presentations that we listened to today. Very, very helpful for us to digest what we've just heard. So again, thanks to all of our presenters for sharing their research findings with us today. I would like to send immense thanks to Annalise for keeping everything going behind the scenes and really making the summit a reality. Finally, thanks to everyone on the call for joining us today. I know your time is precious, and I do appreciate you spending it with us this afternoon. So we do invite you to join us for day 4, the final day of our summit, next Wednesday, March the 3rd, where the topic is going to be improving the system. And your co-hosts will be Lisa Dolovich and Annalise Mathers. So have an enjoyable rest of your day. Take care. And there's more information. Sorry, I missed a slide. More information on Open for you. If you'd like to join the Open mailing list, visit our brand new website, open-pharmacy-research.ca. And more information on the CPE is also provided on that screen. You can contact Annalise for additional information or join the mailing list as provided. Thank you very much.